Hello, everybody. Thank you for joining me today. I am Ahmed SADEK. I am manager of Cairo Hospital for Dermatology and Venereology. I am an executive board member of the International Dermoscopy Society, a representative of the African continent. I am an executive board member of the Egyptian Society of Dermatology and Venereology, as well as key officer for the European Society of Laser and Energy-Based Devices. Today, I'm going to take you in a journey in my Trichoscopy Mastermind games, which I hope you will enjoy. In the science of trichology, we all know that it's not easy to reach a diagnosis, and sometimes we reach more than a single one. We start definitely by history taking, by proper examination of patients, by visual aid devices. We can use them for sure to give us better insight on what's really going on. We can use bedside tests. We can also make very good use of laboratory investigation results. And finally, we are able to reach the diagnosis. For sure, dermoscopy lies in the step of visual aid devices, which also encompasses the magnifying glass and the Woods light. If we search the Medline database using the PubMed search engine, we'll find 336 papers published using the keyword trichoscopy, and almost more than 2/3 of those has been published in the last 5 years, which means that it's a really growing area of interest. And I'm just going to mention that time in the clinic spent with a dermoscopy expert was reported to be the most effective among the US dermatology residents, which highlights the importance of what we are going today. We are going to mimic that you are sitting with me in a hospital setting or in a clinic setting, and I'm going to tell you exactly what I do with each single case and try to answer your questions in order to maximize your experience out of this workshop. But first, I have to tell you that there is a big difference between a dermatoscope and a folliscope. On the left, you can see the images of a folliscope or a USB attached microscope to your laptops. And on the right, you can see the image by dermatoscope, and you can see quite a big difference in the assessment and the appreciation of the follicular ostia. So now let's start our mastermind games. And in these games, I'll take you through 10 scenarios and I'll ask you 25 questions. I'll give you 20 seconds for each question to answer first by yourself, and I'll be counting this on my clock. And afterwards, I'll go on discussing the answers with you during the upcoming 40 minutes. So let's go directly to the first scenario. And in this scenario, when a junior resident like JB from Scratch Show, you know him, comes to you and tells you that he's clinically confident with the case, but he's here just to make sure. So now it's your turn to confirm JB's diagnosis. So this is his first case. He presents with this lady who is in her early 20s, suffering from this localized area of hair loss. And this is a dermoscopic image. I won't say his opinion right away because I'm going to ask you to answer, and I'm giving you 20 seconds. And notice that clock is ticking. Now, what do you think? What's your diagnosis? Is it a case of tinea capitis? It's a case of areata? Is it a case of trichotillomania, or none of the above? What do you think? 10 seconds. The clock is ticking. I see someone who's able to detect the right answer, and time is up. And it's a case of trichotillomania. How did we reach this diagnosis regarding this case? In all the papers published, including ours, in all cases of trichotillomania encountered, there is always 100% appearance of hairs cut at different levels. And you can see this all over here. You can find hair cut at different levels. How do you know that it's a cut hair? Because the tip is not tapered. It's a cut. It's a broad tip. Also, in this case, we can see all those black dots over here, which denotes that the hair is cut off the surface, not at a higher level from the scalp. And by those two findings, we are quite sure that we are dealing with a case of trichotillomania. We also can find some additional signs like subcorneal hemorrhage seen over here. So in this first case, it's a case of trichotillomania. He also brings another case, and he's an adult man who's suffering from this patchy form of hair loss of 3-month duration. And at dermoscopic examination, 20x magnification, we can see this image. And at 70x magnification, we can see it this way. And now the clock starts to tick. You have 20 seconds to decide whether this is a case of tinea capitis, alopecia areata, trichotillomania, or none of the above. What do you think? I believe it's quite easy. It's different than the previous one. Oops, I'm telling you one answer. So it's not trichotillomania, and time is up. And what's this sign we're witnessing right now? This is called trichotylosis. Trichotylosis means that the tip of the hair is a sort of a brush end. And unfortunately, it's not a specific sign. We can see it in many cases where hair is manipulated. So in order to get a proper diagnosis, we have to go back to see the full image. And over here, we can see that we have those black dots, and we have those trichotylotic hairs, but we also see this hair that looks like an exclamation mark hair, where its origin is currently narrower than its tip. So it looks like an exclamation mark hair. And this one really appears with cases of alopecia areata due to the effect of the antibodies on the upgrowing hair. So in this case, we are dealing with a case of alopecia areata. And they also bring this kid who's suffering from this patchy hair loss since birth. And this is a trichoscopic image. And what do you think? What will we do with such a case? Will we monitor? Will we treat medically? Will we reassure and dismiss? Or will we biopsy and go for histopathological assessment? What do you think? The clock is again ticking. And in order to know what we will do, we'll need to reach a diagnosis. So what do you think of this case? This boy has been suffering of patchy hair loss dating since birth. On the temporal region and on dermoscopic image, we can see just vellus hair all around. No hypotrichosis, but vellus hair is occupying the full area. And this is pathognomonic for the diagnosis of temporal triangular alopecia of the scalp, yes. And based on that, we know from some reports that they might respond to minoxidil therapy. If not, no other medical options can be used. So in such a case, based on the age of the kid, we can either treat medically with minoxidil or just reassure and dismiss. In the second scenario, we get a more experienced doctor like Derek from the Grey's Anatomy show. You know him for sure. And he has a clinical differential diagnosis. He's dealing with more advanced cases, and he's looking to know which one is true. And you're there to help him. And he brings this boy with this patchy hair loss. And at higher magnification and micro view. And this is the first dermoscopic image. And this is the periphery, which is really important to assess in cases of focal hair loss. We have to assess the center to detect the prognosis and the periphery to detect the diagnosis. And based on that, I believe it's quite easy right now. What do you think? Is it tinea capitis, areata, trichotillomania, or none of the above? I won't give you much time this time, because yes, we know that we have here the exclamation mark like hers and all those black dots. And yes, this is a case of alopecia areata. Another boy who's younger in age with this almost the same sort of hair loss, but different dermoscopic findings. And what do you think those are? Name them and you reach the diagnosis. I'll call them a corkscrew hair over there and a comma-shaped hair, or the newly coined term, the horseshoe hair. What do you think? It's definitely a tinea capitis, because those findings are seen due to the ectotrix and endotrix affection of hairs. Okay, now to another case, but this one is an adult male with this patchy hair loss. And these are the dermoscopic findings. What do you think? Give you some more time this time. What do you think? Is it a case of tinea capitis, alopecia areata, trichotillomania, or a case of lichen simplex chronicus of the scalp? You can notice that there are hair cut at different levels and black dots, but clinically, there was thickened skin over there with prominent follicular ostia, and dermoscopically, this was violaceous in color, with some whitish lines as seen over here, secondary to chronic rubbing of the skin, leading to lichenification. And yes, this is a case of lichen simplex chronicus that manifests exactly by these patterns, in addition to sometimes some perifollicular scales. Very well. Let's now go to this 72 years old male with this apparent generalized hair loss, but some few papules or micronodules over his right occipital and parietal region of the scalp. And surprisingly, we saw that image dermoscopically. And at the periphery of the lesion, we can see this. So what do you think? Shall be the drug of choice, dapsone, doxycycline, steroid, or isotretinoin. And in order to reach a proper treatment plan, we have to reach a diagnosis first. So what's your diagnosis? Yes, correct. This image shows the findings of early and late DLE. In early DLE, we can see at higher magnification this double-walled yellow plugging of the hair follicles, which are large yellow dots. This is an early case of DLE, but in late one, we can get this diffuse fibrosis and this arbrizing blood vessels appearance. So the diagnostic signs are at the periphery and the prognostic signs are in the center. And the drug of choice will be steroid for sure. Okay, another adult male complaining of patchy hair loss with these nodules of his nape, and definitely this is an ethnically nuki, but regarding the patchy hair loss, what do you think with this hyperpigmentation of the scalp? You see here at a 10x magnification, 20, 30x magnification, 70x magnification. What do you see over there? There is tufting of more than 10 hairs with this starburst appearance in between and the epidermal reaction with diffuse inflammation and erythema. And assessing other parts, there is diffuse cicatrization and there is follicular pustules as well. So this is a case of folliculitis decalvans. And what will be your drug of choice? Dapsone, doxycycline, steroid, isotretinoin? Well, actually, dapsone can help, doxycycline can help, and isotretinoin can help as well, in addition to steroid, because steroid might be needed to suppress inflammation for a short period in the beginning of treatment. So this one is really interesting. What about this adult male with this apparently diffuse hair loss? But dermoscopically, it's quite different. What's your diagnosis? Is it a case of androgenetic alopecia, alopecia areata, none of the above, or both of the above? Simple? Okay, I think it's both of the above. Why is that? Because the diffuse appearance of all those yellow dots denotes that this is a case of alopecia areata. Notice the difference between those yellow dots and the large double-walled yellow dots of the DLE. Also, you can see all the hairs in this area are thin and are usually single hair follicles. So that's why I coined the diagnosis alopecia areata in addition to androgenetic alopecia of the scalp in such patients. So final answer is both. Okay, now to the third scenario where this naughty doctor from the Christine from the Grey's Anatomy show as well, she's also always furious about something. These are clinically similar cases, but dermoscopically different. Please help me. She's facing twin cases like those ones with all those white dots on the hair shafts. And this is the dermoscopic image. And can you help her by answering which one is rarely seen? And to be able to tell which one is rarely seen, the one on the left, on the right, or neither of them, we have to reach a diagnosis. So on the right, we have nits, and those are the full nits with the nymph inside, and those are the empty nits with the translucent appearance and the sharp border. But the full nits are oval at the border and are brownish in color. Notice that the nits are attached to just one side of the hair shaft, and this is a case of head lice infestation for sure. But on the other side, we see whitish cylindrical casts or structures that are encircling the hair, attached all around the hair. And this is a case of white piedra, which is definitely more rarely seen. So our answer is A, the left one. And now to those two young gentlemen suffering from moth-eaten appearance of the scalp due to multiple patches of hair loss. And these are the trichoscopic images. Any clues? Which one can be treated by oral retinoids? What do you think? Shall it be the one on the left, the one on the right, both, or none? Okay, to reach the answer, we have to know the diagnosis. And the one on the left is a case of folliculitis decalvans as described a bit earlier. And the one on the right is a case of lichen planopilaris, known by this cicatrization all over there, this follicular scaling, even this peritubular cast that's surrounding the hair shaft. In addition, we have some tufting of hair over there, but it's less than 5 hairs per tuft in comparison to the large hair tufts in case of folliculitis decalvans seen on the left, which is larger than 5 and rarely over 10. So what shall be treated by oral retinoid? Yes, the one on the left as answered before. Two males suffering from two heart-shaped alopecias. The one on the left is dating since birth. The one on the right is acquired. And the trichoscopic images of the periphery, as we mentioned before, that the diagnostic signs are present at the periphery. Okay, now, which one is rarely seen? Let's diagnose first. Yes, let's diagnose first. The one on the right has all those yellow dots and black dots as well, in addition to shortly cut hairs, and this one is a case of alopecia areata. Yes, correct. The one on the left has this radial arrangement of seen-through hair bulbs at the periphery with cicatrization inside. No evidence of ostia or erupting hair is seen. And this is a case of aplasia cutis congenita. So the one rarely seen is the one on the left. Okay, now to those two ladies with erythematous scaly hair loss. And these are the trichoscopic images. Which one has a single diagnosis? Which one is suffering from just one disorder? The one on the left, the one on the right, or both? or none? And yes, none of them is suffering from a single disorder, because in trichoscopy, yes, we frequently encounter more than one diagnosis. So what the issue? The one on the right is suffering actually from lice as well. Here we see the nits, from diffuse inflammation of the scalp, which was secondary to bacterial and fungal infection as well. The one on the left was suffering from DLE of the scalp. And here we can see the findings of all those vasculature in the area of diffuse fibrosis. And with the application of steroid for a prolonged time to treat the DLE, there was lowered immunity, and she acquired the infection at this site of tinea capitis as well, denoted by this corkscrew hairs. So both cases are suffering from multiple diagnoses. Now at the trunk, hair of the trunk, two adult males suffering from itchy abdomen. And the problem was with the hairs, not the skin. The one on the left was suffering from, you can see the creature grasping to the hair shafts over there, and you can see the knit. This is a case of theriasis corporis. And the one on the right is a case of trichomycosis corporis as well, based on the appearance of the corkscrew appearance of the hair shafts over there and the surrounding inflammation as well. So which one can be an STI? What do you think? Which one can be an STI? Actually, both. So I got this an early answer for you because I know it was not an easy one to guess. Okay, now with the bird, two adult males for sure, suffering from patchy hair loss of the beard area. Okay, what do you think? The one on the right shows background inflammation. The one on the left doesn't show such inflammation. And which one of them can be a form of cicatricial alopecia? What do you think? Which one? The one on the left or the one on the right? Both or none? Okay, the one on the left is showing the characteristic exclamation-like hair. Again, with areas of hypotrichosis, and this is a case of alopecia areata of the beard area. But the one on the right is showing diffuse cicatrization and inflammation and perifollicular scaling over there with a peritubular cast. And this is a case of a lichen planopilaris of the beard area. So which one is cicatricial? The one on the right for sure. But actually, if the one on the left is neglected for long enough, it will be cicatricial as well. So in the fourth scenario, we go for the rare discoveries where everybody's gathering to see what's going on. And this rare discoveries, I won't ask questions because I know they are rare. So let's just assess together. The one on the left side of the slide is the clinical image of the 12 years old girl suffering from this patchy hair loss in the frontal region of the scalp of all her life. It's dating since birth. And dermoscopically, it was triangular alopecia of the scalp, but not located in the temporal region. And yes, this can occur. I've seen it. I've also seen it bilaterally, temporally on the scalp. Now, this lady who's suffering from itchy eyelids, eyelid line per se. And we can find the criminal here. It was also a case of eyelash lice causing this itch. Okay, in the fifth scenario, where dermoscopy reveals surprising findings. And let's see. This is the inner thigh of an adult male who's been suffering from itchings, intense itching at this site. And at the first sight, I couldn't notice this one, but here I'm showing it to you. And the man said, sometimes I can grasp something like this. And he showed me his palm, and it was again a theriasis but this time it's at Theria's pubis. You remember this lady where I showed you and I told you there is combined infection of the scalp with nits over there, and sometimes we can see the criminal itself, and if we are rapid enough, we can catch it grasping to the hair shafts and moving over the scalp. Okay. In the sixth scenario, sometimes more experienced doctors can help us to get to clinical dermoscopic correlation, which will definitely build up. You remember this lady whom I've shown you in the first case in this workshop, and we said she's suffering from trichotillomania for sure, yes. But what about the rest of her scalp? Yes, she's still suffering from haircut at different levels and black dots, but she's also suffering from something else. Can you guess? Again, what are your diagnoses? Is it an androgenetic alopecia, telogen effluvium, alopecia areata, or lichen simplex chronicus with the trichotillomania? The clock is ticking. Yes, it's a case of androgenetic alopecia with trichotillomania because of the variance in the hair shaft thickness seen in the normal areas of the scalp, which is greater than 20% of thin hairs, which is larger than the regular telogen hairs of any normally growing hair in human scalp. And this 52-year-old lady who came suffering from itchy scalp with generalized hair loss. And clinically, you couldn't see much except that she's really suffering from hair loss and erythematous scalp. And on assessment, we could start to see corkscrew hairs that are covered with scales in many occasions. And what's your diagnosis? What do you think? Is it androgenetic alopecia with trichotillomania, telogen effluvium with trichotillomania, androgenetic alopecia with tinea capitis, or telogen effluvium with tinea capitis? And yes, it's a case of androgenetic alopecia with tinea capitis. How do we know? We know from the appearance of the corkscrew hairs for sure that there is zoophilic tinea capitis because of this severe inflammation and the scales surrounding the corkscrew hairs. And based on the appearance of many single hair follicular units and the variation in the hair shaft thickness, it's a case of androgenetic alopecia with tinea capitis. In the seventh scenario, sometimes we might be misled by dermoscopy, but saved by histopathology, like this 4-year-old kid who presented suffering from this diffuse hair loss dating since birth. But we can witness that there is follicular hyperkeratosis all over his scalp, in addition to all over his body as well. It was generalized condition. No vellus or terminal hairs anywhere on the body. And by dermoscopy, you could see that the hair follicles are viable, but all hairs are cut deep inside. And our first impression was that we were dealing with a case of PRP, actually. But by biopsying the hair follicles of the scalp and histopathological examination, it appeared to be a case of keratosis follicularis spinulosa decalvans, which is a genetic disorder which manifests by generalized follicular hyperkeratosis, and hairs are embedded deep in the skin. In the eighth scenario, we can also use trichoscopy at the aesthetic clinic. Yes, like this lady who's suffering from hair loss. She's not aware of what's going on, but we can see the fringe sign apparent at the frontal, parietal, and occipital regions of her scalp as well. And this is assessment, trichoscopic assessment and images of her scalp, and a larger image. And what do you think? Is it a case of traction alopecia? Is it a case of telogen effluvium, androgenetic alopecia, or alopecia areata incognito. Okay, what do we really see? We can see that there are many single hair follicular units. Yes. We can see that there are many vellus hairs. Yes. And that there is variation in the thickness of hair shafts. And this goes with cases of androgenetic alopecia and with tractional alopecia as well. But due to the presence of this fringe sign, which is the long hair at the hairline and decreased hair density and very short hair directly afterwards, this is a case of tractional alopecia, which might be dermoscopically or trichoscopically close in view to the androgenetic alopecia, but clinical correlation will help for sure. Also, this young adult lady with generalized hair loss, but on examination, we could see that there is localized hair loss as well. And again, what did we see? Corkscrew hairs. And the diagnosis is, yes, androgenetic alopecia with tinea capitis. This lady suffering from this hair loss, she's in her early 60s. On the left, you can see the frontal region. On the right, you can see the occipital region. And is it female pattern hair loss, male pattern hair loss, tractional alopecia, or areata incognito? Well, based on the clinical and dermoscopic images, yes, it's a case of male pattern hair loss in a female. And again, this young lady suffering from this hair loss, we can see the fringe sign for sure. And dermoscopically, we can see this and this, and those. So what do you think? We mentioned that there is fractional alopecia, okay? And we've seen follicular pustules and follicular pigmentation, and there is folliculitis. And again, there is also androgenetic alopecia with the tractional alopecia and folliculitis. So the correct answer is C. This one has 3 diagnoses at her scalp, which is quite unlike what we see with the skin, where usually there is just one diagnosis. Okay, in the 9th scenario, we go for the choice of treatment or follow-up by dermoscopy when we, as a team, can think of this together. A boy with alopecia totalis. Dermoscopically, these are the findings. So what will you do? Will you monitor? Will you treat medically? Will you reassure and dismiss? Or will you biopsy and refer for histopathological assessment? Waiting for your answers. What do you think? I think monitoring is not a valid option for alopecia totalis. Yes. Do we need to biopsy? Really? Do you think that we need to biopsy this kid? Can we go for medical treatment, or we just dismiss because we don't think he will respond? Well, based on the dermoscopic images that I see, there are still hair follicles that are viable. There are black dots, there are erupting very short hairs, but yes, he can benefit, or he might benefit from more medical treatment. And I only give up when it's totally fibrosed. This adult male suffering from this patterned hair loss, in his own words, of 10 years duration. He was thinking that he's suffering from androgenetic alopecia. And this is what we saw by high magnification dermoscopy at 30x power. And what do you think? What will we do for this patient? Will we treat surgically, medically, reassure and dismiss, or biopsy and assess by pathology? Okay, in order to reach that, we have to get a clinical dermoscopic differential diagnosis or a definite diagnosis to be sure. And what we see diffuse areas of fibrosis. Definitely there is total absence of hair follicles, replaced with some violations, discoloration at some areas, but no signs of any active form of alopecia. And this is secondary cicatricial alopecia, and we cannot know the primary cause, what it is, because there are no active lesions. That's what earlier was coined as pseudopelade of Brock. So in such cases, the only treatment we can do is surgical transplantation of hair. This male who has a history of alopecia areata and has this area of hair loss of 3-month duration. And this is what we could see by dermoscopy. We could see those rosette-like structures, which are 4 rounded white circles, which are in close proximity arranged as a rosette. And we see absence of follicular ostia at this area with a black dot over here and an exclamation mark here. So this is definitely a case of areata. But what happened? This was irritated chemically. And this is evidenced by the PIH, the post-inflammatory hyperpigmentation that I can see at the periphery of the lesion as well. So in such case, we have to suppress the inflammation that's going on. And that's why I will go for medical treatment to suppress the inflammation first, to decrease the insult that occurred to the skin in order to be able to have a chance to grow some hair when I'm going to treat the areata later on. But first, I have to save the skin from any cicatrization. Similarly, and sadly, this was a similar case, but on a larger area. And you can see over here, even the lichenification secondary to the chronic itching and irritation of the skin. And in such case, yes, we have to treat medically as well in order to suppress the inflammation, to be able to have a chance for hair regrowth afterwards. That was the last question, but I have a last scenario, which is about when you review the literature to see what's going on in other places of the world. Like this really interesting paper that was published by Rossi et al. Almost 6 years ago in the Journal of the European Academy of Dermatology and Venereology about the dermoscopic findings of all the clinical differential diagnosis of androgenetic alopecia, like the frontal fibrosing alopecia. And for the frontal fibrosing alopecia, we all know that clinically there is a recession of the anterior and the temporoparietal hairlines, and dermoscopically we never see vellus hair at the original site of the hairline, but we only see terminal hairs that are regressing, that are usually single hair. Sometimes we see deserted single hair in an island. For the hereditary hypotrichosis simplex, there is decreased number of hair follicles, there is decreased thickness of hair shafts, there is single hair follicular units all over the scalp, dating since birth. And that's how we differentiate this condition. And also the pubertal and sometimes pre-pubertal hairline phenotypic variants, which are sort of early androgenetic alopecia. And I've been seeing such cases in an increasing number, especially those with strong family history of androgenetic alopecia manifesting in their father and mother. And the pseudo-androgenetic alopecia, where there is bitemporal regression with preservation of the anterior hairline with the same dermoscopic findings as in cases of androgenetic alopecia. I'd like to end this workshop by those 2 slides, which is a collection of all the investigations that you can perform to differentiate first cases of generalized hair loss. You can take photographs of this. It's a really important table, which I've worked on. And you can find the androgenetic alopecia, the telogen effluvium, the anagen effluvium, the trichotillomania, the alopecia areata, the tractional alopecia, and the pressure alopecia, and the different findings in the hair pull test, the trichogram, the trichoscopy, the polioscopy, the phototrichogram, the Woods light, if even we go for culture with blood tests, and for biopsy. And this one is for the causes of localized hair loss like tinea capitis, DLE, lichen planopilaris, folliculitis decalvans, acne keloidalis, central centrifugal cicatricial alopecia of the scalp, and dissecting cellulites. I hope this will be helpful for you in practice. And I thank you very much for joining me for today. And I wish you a very beneficial conference. Thank you.